Welcome to this week's session. Glad to have Bimal Sahoo, our Senior RCM Product Manager, back with us. This week's topic is one that keeps most providers up at night, and that's denials. So today we're going to talk about how you can effectively manage your denials. But as we're talking about denials, I think it's also really important to think about denials as not just a back-end revenue cycle function, but think about where these denials are coming from, where they originate. Denials are, as everyone knows, impacted at every stage of the revenue cycle, from patient access activities, things like intake, eligibility, and benefits verification, prior authorization, all the way through mid-rev cycle, like coding, using the right modifiers, through billing, and so on and so forth. So we see providers come to us every day with denial challenges. And part of what we do is work with them to identify what the root cause of those denials are, and then help them to put solutions in place for that step of the revenue cycle. So as we jump in, just keep in mind that knowing where your denials are coming from is critical to resolving them. So let's go ahead and jump right in. Welcome back, Bimal. Happy to have you here.
Thank you for inviting me over.
Yeah, absolutely. So let's jump right in. What are the denial trends that we're seeing in the industry today?
Yeah, glad we are somewhat over the pandemic now. So we are seeing that the regular revenue cycle picking up as we are heading towards middle of 2022, things kind of stabilizing. But not so great from the denials perspective. What we are still seeing is there's a whole lot of denials happening. It even has gotten worse. We see around 30% uptick in terms of the total number of denials or dollars that are getting impacted. And we're seeing a whole lot of denials happening, mostly coming from the patient access side, authorization related, eligibility related, non-covered services related. So those are still in the uptick. So we are still seeing those denials kind of occurring. We're also seeing mid-cycle issues around coding, bundling, incorrect E&M codes being used, because of which denials are also happening. So we are seeing those also being seeing an upward trend, and all of these, as you would have already expected, it's kind of being from the commercial payers mostly, and that's where we are seeing a little bit of risk in the revenue cycle. But there are smarter revenue cycle teams who know how to go through this difficult phase and kind of turn it around.
Why do you think we're seeing that upward trend? Any indication of what's causing that?
Yeah, especially I think payer guidelines have been changing quite a bit in the recent past, and it's kind of very difficult to kind of track that across different, even the national payers. If you take their guidelines and policies are a little bit different across different states. What kind of codes do you use where, and what policies do you have to follow through the billing, and the other processes are different. For what codes do you need to take authorizations for in the patient access in the front end? That is also different across different states, across different plans and group members plans. So that's one of those critical areas where we are seeing that that the teams who are kind of managing the revenue cycle need to focus better in terms of understanding those guidelines and making sure that the claims are clean and get paid.
What are the metrics that providers should be tracking for denials, and how should they define those metrics?
Sure, I think this is a very important, valid question. It's actually unclear, and there are not very strict guidelines around how do you report your denials, how do you track your denials across all. Even if you consider HFM benchmarks or MAP keys, it's kind of difficult to kind of follow those guidelines in practice because your billing systems don't store or generate that data at that level to be able to map or calculate that. So in lieu of that, what I would suggest is to go ahead with first understanding your data from your remittances, 835s. Kind of then go ahead and categorize your remittances by dividing them into two parts. One, specifically your zero pay denials, and second, you carve out the partial pay denials, right? And trying to kind of monitor both aspects and see from the total number of claims that you got remitted for, what is your denial rate in zero pay bucket and in your partial pay bucket, and kind of keep on monitoring that. That's one way of doing that. Along with it, what's also important is to define what is a denial. And that relates to your denial mapping activity. I'm sure many folks over here in this forum would express their concerns about, hey, we know that this is not a denial, but it's kind of getting popped up, or we are seeing some card codes or RAR codes that are getting missed out and not getting mapped, and it's kind of passing under our radar, and we're not seeing reimbursements at the end, but it didn't get captured in our denial reporting or in our metrics. So it's kind of important to configure your reporting systems, your billing systems in a way that you kind of map those your denials to a specific reason, and have a owner against each of them. So each of your card codes, you could go ahead with assigning, if it's a denial, would you consider that as a denial, or would you not consider that as a denial? Because some of your card codes are just your payments, and they're just for your reference only. So in those cases, try to kind of categorize that as a denial or a non-denial. And then going forward, you should also pay attention to your RAR codes, because in some cases, your claim adjustment reason codes or the card codes would not give you specifics around what the denial is all about, how would you go about appealing or resolving that, but your remarks code would. So ensure that your systems are capturing that information, and if not, then use a third-party playbook to kind of get those information out extracted, and you can apply different rules to be able to analyze that information and apply a certain reason to that particular RAR code. Now, you should also maintain a denial hierarchy. By that, what I mean is you could have a combination of your card codes and RAR codes, but what does that specifically mean? So in those cases, I would suggest that you should have a denial hierarchy in place. And in that circumstances, you know exactly what the reason code for the denial is. So now going about that, you should then be able to understand what your exact denial rates are, what your zero pays and your partial pay denial rates are.
What other data points related to denials should revenue cycle teams be looking at, and how can they channel this information to prevent future denials?
Perfect. So I think to prevent denials from happening, it has to be an amalgamation of people, process, and technology, right? As we all say, any business process improvements, any improvements, you need to kind of have a tight culture that kind of binds all three things, process, people, and technology. But I would try to add the third element about data driven, or the fourth element of a data driven approach to solving this, right? So as we discussed about those metrics we talked about, now it comes down to first understanding, getting those information out of your billing systems, understanding those different denials that you are kind of getting. And after you kind of channelize that, then take it over and have an owner who is looking at those specific denial groups. So what you may see is suddenly there is a spike in clinical denials related to authorizations, related to medical necessities. So are there specific teams or processes involved who are going to take a root cause analysis on that data that you're seeing and be able to then champion some process improvements in your organization? It could be some training opportunities. It could be some educational opportunities for billers. It could be something for the front end stuff that they should take care of. So how do we take insights from the data and dissipate it across the organization is a pretty important thing to manage denials, because it's just not the backend team who is going to solve everything for you. That information or that insight of why this problem is happening, what is the root cause behind it, and what process improvement should you undertake, that needs to kind of flow in to the top of the revenue cycle, to the patient access teams, to the front office, to the billing teams, to the coding teams, and so on and so forth. The next level of way in which you should kind of monitor this, it should just not be at the denial reason or the denial groups level that you would have categorized, but also go a little bit deeper into understanding for what payers are you seeing these trends happening. Let's say your denial rate for this particular payer for a specific denial group like authorization is 3% or 2% was in the last month. What suddenly happened that it moved over or bumped up to like 5% this month? So if you're tracking those metrics, it's going to give you an indicator where the problem is, and it's going to make you more proactive to manage those denials, to prevent them, have those processes in place so that such denials don't happen for you in the future. So that would be my suggestion in how you should go about looking at data, turning those insights into actions to prevent denials from happening.
Great. What strategies can AR teams use to try to overturn denials, recover revenue? Any thoughts on that?
Yeah, generically denials is something like some of part of it is controllable in nature, some part of it is non-controllable in nature. When I mention something which is controllable, is what I would say like, hey, have you gone through the payer guidelines? Do you understand what things need to be attached with the claim? Do you know if authorization was required for certain services? Would you know that these are the sort of edits that needed to be happened onto the claim before it was sent out to the payer? So these are under your control. If you are good at your processes, you kind of already know the payer guidelines, you know what are the billing guidelines, the coding guidelines. You would definitely be able to clean up your claims and send clean claims out of your door and get paid on the first part. But if you're not seeing that and you're seeing those kind of denials happening, then that's absolutely under your control. You should definitely pay attention to that, because these are pretty easy to fix once you know what exactly you have to fix. So doing those root cause analysis, understanding them, channelizing and championing your process improvements will definitely help you resolve those kind of denials. Now, there are other uncontrollable denials that are like very difficult to track, because there's a very specific new guideline that came into the process which you are not aware of, but you would discover sometime later, or there is a level of additional medical documentation that a particular payer is asking for specific procedures that you were not aware of as a trend, and it had not been happening before. So you are not aware of that. So those are the cases that is typically out of your control. So I would say don't pay too much focus on it, but the ones that are definitely under your control, like obtaining authorization for the relevant procedures that you are performing for the relevant DRGs. Are you doing the right kind of bundling, unbundling of your procedures, in attaching the right codes or specifying the right codes, because it may require a little tweak in terms of how you would code it for a specific pair for one versus the other, depending on the guidelines. So if you are kind of aware of it, it would be very easy for you to control the ones that you definitely can prevent from happening. So I would suggest the team to first start focusing on them, have a process in place so that they have a good foothold on the controllable denials, and then kind of think about how they can be more proactive about uncontrollable denials or things that are suddenly happening, and be able to quickly understand what's happening, not be much more proactive to it, and bring it to the notice of your broader denial review team, who can then take subsequent corrective actions. So this is what I would suggest as a good denial management practice that every organization should imbibe.
Switch gears and talk about benchmarks, KPIs. How should denial teams benchmark performance, and how can they take that data and use it to improve?
Sure. When it comes to denials, I think it's not very different. When AR and denial management teams actually work on what's outstanding, you have broadly like two categories, right? If I would say, one is your claims that you need to do a follow-up on, and let's take the second case, which are your denials that you need to kind of resolve in overtime, right? When it comes to denials, I think it's very important for you to understand, is it an initial denial or is it a subsequent denial? Because it could so happen that there was an initial denial which you tried to appeal or resubmit a claim against it, and then you got a subsequent denial, right? So adding that and would mean that you are kind of double counting your denials, which you should try to avoid. But at the same time, you should always measure what is your success rate in overturning those denials out. So how much of denials that you initially got overturned into payments, right? Not just adjustments, liquidation in your write-offs you're going to do, but it's very important to kind of measure what's your success on overturning those denials to get paid. So that should be an important metric to kind of monitor. And you should give yourself at least 3 months. So you know your initial denial was on day 0. You try to monitor those claims and see how much payments have you received in the next 90 days, right? So that should be your performance in a benchmark to see that how much have you overturned in terms of denial. The second is there are different ways in which you try to resolve your denials. It could be, as I mentioned about earlier, a little while earlier, it could be about resubmitting the claim. It could be about appealing it. So if it's an appeal, right? So make sure that the number of appeals that you send, you also are measuring how much percentage of those appeals are getting overturned and are leading to a success in payments. Because you might realize that from those appeals, if the payments are not coming up, so there is something wrong in the appeal process that you're doing. Either you're not following the right appeals templates, or you're not providing the specific information that is required for that appeal to get overturned, or you might be losing on some of the finer details, right? So measuring those success across, always I would say, always measure across payers, across your DRGs, your service categories, and your facilities, locations, or states, right? So combining these two, always take a look at those metrics and see what has been successful for you and what has not been successful for you. So if you kind of analyze both these things together, you already know like your denials, what kind of denials for what payers are you able to successfully overturn, and then for what appeals you're seeing a success in terms of your collection. So combining those two could give you a good strategy to see that if I have an incoming denial flow of hundreds and thousands of dollars, I know for sure based on these historical metrics, these are the buckets of denials and denials that I should touch, which is going to give me with high confidence these dollars, because I have been able to overturn them in the past, right? There's no point going after denials and appealing claims where you know that you have never historically gotten paid for it, right? I mean, there could be a separate exercise about why you did not get paid for it, but if you know for sure that these are the certain buckets that you never are going to get for it, then why work and waste your effort on those? You could actually work on something else, because there's always a whole lot of denials and you're always short staffed, and you need to realize your cash faster than later. So work on the ones where there is the best chance of recoverability. So I would kind of use these metrics to kind of understand why and how you should go about recovering from your denials as well, uh, and benchmark your metrics against some of the KPIs that I mentioned about your appeal success rate, about your denial overturn rates, and how it's trending across payers, and go about that.
Great. So want to get everyone time to ask any questions that you might have. But while we're doing that, Bimal, if you could give everybody one call to action today in terms of denials that they can take with them and get started on right away, what would it be?
I would actually start off not just giving one, because it's very difficult to give one input. But I would suggest to start off with your denial mapping exercise and your denial hierarchies, because that is very important for you to understand the root cause of denials, and then channelize those information and process improvements along with other teams, patient access, coding, that you should definitely reach out to, have them take ownership of why these denials are happening, right? So because backend denial management is just not about recovering AR or denials. It's also about imparting those knowledge so that these denials don't happen in the future. So that's one. The second I would say is always pay attention to your payer guidelines. Have a team that focuses on it, or whenever AR and denial management teams are working on something and they find it, always push that into your knowledge repository and kind of disseminate that information across the board. And third, I would say, keep a good hold on your timely filing limits and appeal limits across your payers. Because what happens is, you may think that this is Blue Cross Blue Shield plan, and it's typically 90 days or 120 days as my appeal limit or my filing limit. But what you would realize specifically, that when it goes to that specific payer plan, it could have a very different timely filing and appeal limit as compared to what you had thought at a broader level or at a national level. So they change and vary. So depending on how granular you are storing your information at a payer level, always try to do that mapping and prioritize your denials and your AR follow-up activities based on that. And always do a review on your appeal process or a resubmission process. You need to be very clear about what you're going to do with that denial, because if you incorrectly appeal a denial, you might lose the opportunity to resubmit the claim, and you're never going to get paid on that claim because you're going to miss your timely filing limit, right? Because you thought as if I'm going to appeal it, but not necessarily all claims need to appeal. Get appeal. There might be ways that you can resubmit and rectify that claim and get paid in a much faster way, resetting your clock rather than going through the appeal route. So these are some of these tips that I would try to provide that everybody could take benefit of.
Great. So we've got another question for you, Bimal. How can machine learning and augmented intelligence help in predicting recovering AR, particularly for aging AR greater than 90 days?
Sure. So I think there have been many stabs at it, right? So how do you kind of try to predict recoverability? In essence, your end goal is to understand, is my denial or my AR that's outstanding, is it going to be collectible or not, right? So one aspect to it is your aging, but then there are other aspects about what kind of denial, what success rates have you seen across that denial, what's the complexity level of that denial, and what the current status of that particular claim is, right? So there are multiple, predictor variables that go into a machine learning model to try to understand, given that this is the state of a claim, for it belongs to this payer for this particular CPT code or this particular revenue code, DRG, it belongs to this particular patient who is in this demographic, along with what the specific payer plan is, what the specific denial code is. Given all of that, the machine learning models actually try to build a decision tree into understanding, hey, first of all, is it recoverable? Yes or no? And if it is recoverable, then what is my confidence in recovering that money, and to what extent? So machine learning models try to understand or learn from historical data to come up with this. And we've seen some quite a great success in how this gets implemented, because you can always see there's one claim that has $2,000 versus there's another claim that is $1,000 only. But you would see a higher confidence in recovering the $1,000 claims. And that's much better than where there is only a 5 or 10% chance of recovering from a $2,000, right? So I would always prefer where a claim which even has a lower dollar value that is outstanding, but has a very high confidence in turning that over, right? So we would want to go off with those payoff metrics to understand which claims do we target and do we go about. So that's how AI and machine learning models kind of help you direct to the specific claims, and also help you prioritize when it should be worked, because it can take into account your timely filing limits, appeal limits, and can tell you, hey, you have two claims who have priorities kind of fighting for when to be touched, but one can wait a little while you should focus on the other one because it's timely filing limits and your chance and its chances of recoverability is a little bit faster. So you prioritize one versus the other. So yeah, some of this decision making that when you lead a human to do can introduce some biases, but if you let a machine learning model or a AI prediction model to kind of take it over, can lead to better outcomes.
It's a really good point, Bimal. I think especially with all of the staffing issues that we're seeing, folks are really working with lean teams. And so having some direction on what to prioritize versus, just kind of leaving it up in the air is helpful and more effective for sure. In your opinion, what is the healthy denial percentage for a practice?
It really depends on different specialties. We see in case of orthopedics or cardiology, they're more clinical oriented denials than others, technical denials. And I would say a healthy rate to be within like 4 to 6%. That would be a good benchmark to have. Whereas in some outpatient services or maybe diagnostic radiology, if you take into account, we see denial rates going up and above 9%, 10%, which is still okay because you're dealing with other referring providers to fetch you information, and there is always a chance of some misinformation, something that you don't have to file a claim in its cleanest manner. So that's still understandable. A good denial rate could be between like 8 to 10% for something like radiology. For hospitals, I think they're much more in control, right? You have your patients, they are staying with you, and then you have all the details about their eligibility. If you needed to take authorization, you should be much more proactive. You know their entire case history, right? So in those cases, I think a good benchmark would be to be between those 3 to 5% for hospitals would be a good metric. Again, it varies for the different service categories, but for hospitals, acute care, I would suggest that to be within 5%.
Great. Thanks for answering that. Thanks everyone again for joining. We hope to see you back here next week. And if you've got any thoughts on future topics that you would like to see us cover, let us know. We'd love to hear them. So have a great one, everybody.
Thank you, everyone.